Good evening, everyone. My name is Elisheba O'Day. I'm a medical student at the University of Illinois College of Medicine at Peoria. Thank you for joining us and for arriving camera ready and for keeping your cameras on. We are so happy to have you. Tonight's inaugural annual Ophthalmology Virtual Program Series is brought to you by UEComp's Ophthalmology Student Interest Group and Sharing the Scope, a medical student-run initiative sharing OptoScoop with all aspiring ophthalmologists, especially medical students without home programs. Before we get started tonight, I would like to extend a warm greeting and thank you to all of our esteemed panelists and to all of our attendees. Thank you so much for taking the time during your winter breaks to be with us tonight. Here is our agenda. So we're going to start with a welcome. Then we're going to move on to an introduction of our esteemed panelists. We'll go over the prepared questions and then we'll take questions from the audience. At this time, may the event organizers introduce themselves, starting with Cecilia.
Hi, everyone. Can you hear me okay? Thanks for putting this on. I'm so excited to get to know different subspecialties of ophthalmology. I am the secretary of the Ophthalmology Interest Group here at the University of Illinois in Peoria, and I'm a first-year medical student.
Hi guys, my name is David. I'm M3 at UIComp, and I'm also working with Sheba on this project.
Okay, now Allison, can you do our speaker bios, please?
Yes. So as Elisheba had mentioned, we have a very esteemed group of panelists today. So please bear with me as I try to condense all of their accomplishments down into a brief introduction. But starting with Dr. Paul Phelps, he had completed his medical education at Drexel University. He then further cultivated his interest in oculoplastic and reconstructive surgery while studying as a Fulbright scholar at one of the world's most productive eye hospitals in India at the Arvind Eye Institute. He went on to complete his residency at Stroger Hospital, Cook County, followed by fellowship at the University of Wisconsin-Madison in ophthalmic pathology. He rounded out his ophthalmic training as he pursued oculofacial plastic surgery fellowship at the Albany Medical Center. Dr. Phelps now serves as he then went on to serve at an academic capacity at the University of Chicago and North Shore University Health System, providing mentorship to ophthalmology and plastic surgery residents. Following his academic pursuits, Dr. Phelps went on to found the Chicago Oculofacial and Plastic Surgery Group, where he continues to currently practice. So thank you, Dr. Phelps, for joining us.
Thanks.
Next, we have Dr. Monica Dweck. She is a graduate from SUNY Downstate College of Medicine in New York. She completed her residency training in ophthalmology at the New York Eye and Ear Infirmary, making her the first African-American woman in their 180-year history. She then went on to become the first woman of color in the country to receive a fellowship in oculoplastic and reconstructive surgery training at the Cleveland Clinic. She served as the Director of Oculoplastic Surgery, Vice Chair and Residency Program Director in the Department of Ophthalmology at SUNY Downstate Medical Center, and is annually recognized as one of the top doctors in the field by the U.S. News and World Report and New York Times Magazine. Dr. Dweck continues her commitment to patients in the Brooklyn Heights community as an Associate Professor of Ophthalmology and Medical Education at the Icahn School of Medicine at Mount Sinai. Thank you, Dr. Dweck, for joining us.
If I can just interrupt for 1 second. I haven't been in Brooklyn Heights for a few years. I'm at the main campus of Mount Sinai for the last few years.
Oh, thank you. Next, we have Dr. Ann Tran. She earned AOA honors during her medical training at the University of Wisconsin-Madison. She then trained at the world-renowned Bascom Palmer Eye Institute for her residency. Following residency, she completed ophthalmic plastic and reconstructive surgery fellowship in New York City in conjunction with Columbia, Cornell, NYU, Bellevue, and Manhattan Eye and Ear Throat Hospital. Currently, Dr. Tran serves as an assistant professor at UIC's Illinois Eye and Ear Infirmary. With over 60 research publications, 15 book chapters, and numerous teaching awards, Dr. Tran has made exceptional contributions to the fields of oculoplastics. Thank you, Dr. Tran, for joining us.
Thanks for having me tonight.
And lastly, we have Dr. Eleanor Kim. She completed her medical education and ophthalmology residency training at Weill Cornell Medical Center, followed by her oculoplastic and facial reconstructive surgery fellowship. She has authored numerous publications spanning across the medical, surgical, and social aspects of ophthalmology. Dr. Kim continues to serve her New York community as a clinical assistant professor in the Department of Ophthalmology at NYU School of Medicine and as the Diversity, Equity, and Inclusion Lead at the Department of Ophthalmology. Thank you to Dr. Kim, as well as to all of our panelists for being with us tonight.
Thank you, Allison. Attendees have submitted several questions, which we will discuss tonight. We will begin with our first question. What is your ophthalmology origin story? Please tell us about your aha moment in medical school that led you to ophthalmology.
I guess I'll start. So I was in medical school in the early 1980s. Can you hear me okay? Okay. And initially, when I was an undergraduate at Princeton University, I knew I was going into psychiatry. And while I was there, I did everything with that goal. When I got to medical school, I took gross anatomy and realized I wanted to be a surgeon. So I went around and observed different surgeries. Finally met the chair of ophthalmology who told me I should consider ophthalmology. He also advised that I apply for the NIH Summer Research Fellowship. Now, I was already in my second year of medical school, and they usually only accept students after the first year, but I was accepted and had to apply to ask my medical school if I could defer the start of my third year in order to do this 3-month fellowship. So I did that 3 months. It was absolutely fantastic. It absolutely made me decide this is what I wanted to do. And so at that point, I was completely focused on going into ophthalmology.
I can go next. I was a researcher at MIT working with fruit flies and volunteering at Mass General Hospital to try to get volunteer experience to apply for med school. So I hadn't gotten to med school yet. And I was working with fruit flies and I was injecting like micro injecting DNA into the fruit fly embryos to like make a transgenic fruit fly. And I was pretty good at it. So I was like, oh, this is really cool. I could do like microsurgery. And then I explored, the idea of doing microsurgery and I found the field of ophthalmology. So that's how I, got interested.
I can go next. I was initially interested in medicine. I was very interested in geriatrics for a while. So, I think, and I think ophthalmology is one of those fields that is kind of small, that if you don't have that early exposure in medical school or through a family member or, the connection, that it's sort of hard to find it unless you kind of stumble upon it, which is, I think, sort of what I did. And at some point I decided I really want to do surgery. So I was like kind of trying to look at the surgical subspecialties. And I do think for ophthalmology and including oculoplastics, that you do really have to like surgery and that part of the field. I decided I liked surgery and I was kind of exploring ENT for a while. And then I decided I liked ophthalmology and doing oculoplastics. Actually, there's a lot of crossover with ENT. I think that's in one of the questions, but it's nice to kind of come full circle and sort of do a little bit of that in what I do now.
So kind of very similar to like Ellie's story. So the first doctor I ever shadowed was an ophthalmologist at the Veterans Hospital. And so it kind of just, I just kind of got lucky. And then really deciding during third year, once I knew I wanted like a surgical subspecialty, I decided to just like re-explore ophthalmology, but then kind of look at all the different like subspecialties. And so I found that, on my general surgery rotation, I loved plastic surgery, but then there is this like great subspecialty within ophthalmology called oculoplastics. And I think that just kind of knowing that I could kind of merge those two interests really sealed the deal for me.
Okay, thank you so much for taking us through your origin story. We have some pre-med students and M1s on the call, and perhaps they're not yet sold on ophthalmology. So if you had to tell them why they should choose ophthalmology, what would you all say?
I'll take that again. So for oculoplastic surgery in particular, there are many, many, many different types of procedures that we do, and we get to work all over the body. But the eye specifically is such an amazing organ. And it's basically, because it's an extension of the brain, there's so much that's going on, and it's highly technological, and lots of research is going on, and you have choices. You can do microsurgery, or you could do larger field surgery, which is often the case with oculoplastic surgery. But making the decision to go into ophthalmology, it was really the organ itself that fascinated me, that so much can be done to save people's vision. And vision is the most valued sense. And so it's really a blessing that we're able to perform that function for our patients.
It's such an important sense to people. And there are some surgeries where they prioritize, they talk about, saving life and limb, and vision is sort of kind of really falls into that category of something that's so important to someone that they may not want to, that you have to really prioritize it in that manner. And it is such an important sense. Even in a field like oculoplastics, we do kind of like it's more known in like cornea to kind of give people that 20/20 and stuff. But even in oculoplastics, you'll do surgeries where even lifting the lid or doing certain procedures, you can improve vision and have patients come back to you seeing better. So I think, and Dr. Dweck was a program director before as well, and so kind of get used to sort of promoting the field. But one of the things that I say a lot is that it's the perfect combination of medicine and surgery, and it really kind of toes that line, and that you're able to have the continuity of care patients that a lot of people in medicine have, but you're able to do surgery at the same time. And some people also describe it as the primary care of surgical subspecialties. So you are kind of dealing with a lot of systemic diseases like diabetes, and you do have the opportunity to see patients and families of patients. And I think that's something that to be a surgeon and to be able to have that, I think is special.
I think everybody has already taken all the good reasons, you guys. But I also, in my origin story, I was interested in surgery from high school age. I shadowed a cardiothoracic surgeon, but it was very overwhelming to me, the idea of, standing for hours, like doing a heart transplant. And when I found ophthalmology, I found you can do like really quick surgeries and help people so much in such a short time. Also, you see patients with like acute disease. It's not like internal medicine where people are neglecting their chronic disease for years and years. Like people show up with glaucoma and you can do a surgery and fix and help them like immediately, so that's great. And I got attracted to ophthalmology because of the microsurgery and how it could be a bloodless surgery and how cool that was. But now I've kind of drifted more back to macro surgery and oculoplastics. I almost never use a microscope. But I love it because we're trained to use a microscope, where we use all these very delicate instruments and are trained as sort of microsurgeons, but we're doing macro surgery on the face. So, oculoplastics is the best. Ophthalmology is also, really great, but I would echo oculoplastics is so much better than, my alternative would be, Mohs surgery, being a Mohs surgeon or ENT facial plastics or, plastic surgeon. So I'm glad oculoplastics worked out for me.
And I think you'll find that like within the clinic, there's a lot of variety outside of even the surgical aspect. Like your clinics may be filled with injections or with lasers. Like there's always all these different like gadgets and like cool ophthalmic tools that you're using. And so it's just a very exciting field.
Thank you so much for sharing that. If you guys could go back, what advice would you give to yourself as a first-year medical student?
I'll take this first. I would encourage myself to learn about every field, because even if you get fixated on, hey, I want to be really good at ophthalmology, a good ophthalmologist is a good medical doctor, so you're not going to be someone who, you're not going to be great at oculoplastics or ophthalmology if you don't know anything about the endocrinology part of things or the, other parts of medicine that are so important.
I would say probably to seek out mentorship more, and to not be afraid to be proactive about it. I think there's really a two-way street in being kind of a mentor and a mentee. And there is a way of being an active mentee that really helps to kind of establish that relationship and grow that relationship. As a lot of mentors are busy, but that doesn't mean that they don't want to spend the time with their mentees but sometimes they need reminders and things. And it doesn't mean that you're being, overly aggressive by doing those things. But I think just trying to kind of form those relationships and to kind of be proactive about it and sort of when you talk to your mentors, kind of try to you really get the most out of the relationship and take it to the next level. So, and that'll help you in terms of finding your interests, finding research, and just forming relationships that really inspire you.
I think one other thing that I wish I would have done as like an M1 person, just kind of outside of like ophthalmology related, is like maybe have considered doing something that consisted of like a global experience, especially during that summer between M1 and then M2 year. I think it's very eye-opening to kind of see how medicine is done kind of outside, and no matter what field you go into, I think you'll gain something from that experience.
As I mentioned earlier, I got a late start, relatively speaking, in terms of being interested. So I would suggest the earlier you start focusing on it, the earlier you get the exposure and the experience, the better. And it has become even more competitive than it used to be. And research has taken on a much larger role, especially with step one being pass-fail. So if you're interested as an M1, get the experience, get the exposure, shadow, join the American Academy of Ophthalmology, watch surgical videos, go to the OR, start nurturing relationships within the community so that you can get as much exposure as possible, and publish if you can. Some type of scholarly work will certainly enhance your portfolio to make you more competitive to enter the field.
Thank you. I think the responses you all gave speak to the next question, which is what summer opportunities should students who are in their M1 year pursue between their M1 and M2 year? So anything else to add on other than the shadowing experiences, nurturing relationships, getting time in the OR?
like the interest groups and outreach groups are good things to do. That's one of the first places I got exposed, how I learned how to use a tono pen at like a outreach clinic. So that's a good way to spend time.
I would suggest also with whatever scholarly work that you do, a research project, get as much leverage out of that project as you can. You can have a published manuscript. You could present at your medical school research day. You can present at various other organizations and societies. Get as much leverage as you can out of that one project, because that only, again, enhances your portfolio.
And then I'm not sure if you guys have the same kind of like summer research programs that the University of like the Chicago campus has. But I know that they have like 6 weeks like paid like research projects that you could pursue. So I would definitely look into those resources, because I know that anyone within our department would love to have you guys come join and do a extensive research project, whether it's basic science or clinical research.
Okay, our next question is, what recommendations do you guys have for medical students who want to learn the practical aspects of ophthalmology? If a student is hitting a mentorship roadblock, are any of you available to serve as mentors, provide opportunities, or give advice as to how we can form these nurturing mentorship relationships?
So it's possible for me to be a mentor through Cook County. As part of like my CV, I'm actually there 1 day a week. I spent my whole day there today at Cook County Health. So I'm there like every Wednesday, and we have medical students rotating through. I'll put in the chat the email address to reach the person who coordinates that, Dr. Shweta, and Lisa Thompson's the program director, but I'll put their email address in here if you want to. I can be your mentor through Cook County. In my private office, it's a little bit different right now. That's where I spend 4 days a week, and it's growing and building. In the introduction, we said that I had a group, but it's really just me right now, although it's growing very fast.
Thank you, Dr. Phelps, and congratulations on that growth.
I just wanted to put a shout out for a program that's offered through American Academy of Ophthalmology called Minority Ophthalmology Mentoring Program, or MOM. And there's a deadline this month for signing up to be a mentee or applying to be a mentee with that program. I think it's January 31st. So I do it for those students who are underrepresented in medicine. It's really a great opportunity. It's a very structured way to have a relationship with a mentor. There are opportunities to attend the AAO conference where there's other specialized education in regards to ophthalmology and applying into ophthalmology. So, if you have the opportunity to apply and haven't yet, then I think it's a really nice program.
And Women in Ophthalmology also has something very, very similar that you can look up online.
Okay, I'm actually a part of MOM, and it's life-changing, so I would also encourage anyone. I think you have to be an M1 and underrepresented in medicine to apply, and they have 2 deadlines, and I would encourage you to apply for the first one, the early one in January. The next question is, did any of you pursue a research year? What advice would you share as we pursue ophthalmology-specific research? And you spoke to this already, but how important is research for our residency applications?
I think research is super important, especially just because it shows your interest in the field. And that is something where every institution, they're going to kind of look at how many like meaningful like publications that you have. So I think in terms of like pursuing a research year, you kind of have to see based on like how much you're able to do at medical school, and kind of the rest of your application. I would, I personally didn't take a research year, but I made it a big priority during like third year, during like after clinical hours or whatever, to kind of do as many like small projects as much as possible to be able to be involved. So I think everyone has to kind of make that decision by themselves based on like what they're able to balance with their clinical years, and how the rest of your like profile is.
I think that's a question that comes up a lot. I'm sorry, my son's practicing trumpet, not so well. He's like a band concert tomorrow, so I apologize. But I think, and what I've always told students is really, you have to be interested in the topic and passionate about it to do that, because it's a year and it's really a commitment. So I think if you don't find that project or don't have that interest in it, then there are avenues to do research and show that commitment to the field within your allotted time at medical school. I think for most curriculum now, I think that there are those flex months or elective months where you can do that. So I think it's always for people who are interested in research or becoming a clinician scientist, I think it's a very nice thing to do that. But I also wouldn't do it just to kind of like advance your application alone.
I have to agree with Dr. Kim on that, because there's no guarantee that you'll match even after a scholarly year or research year. There are, however, pre-residency fellowships for those who do feel they need to take a research year. And there's a whole, several of them around the country that exist. No guarantee whatsoever that you'll match at that point. But if you feel that that's something you need to do, then you should probably do it, because it will strengthen your application for whatever you go into. And so it can also be very worthwhile. One of the things that you really need to look at in evaluating that scholarly year is, will it produce research or scholarly work of some type? Because that is where people are usually lacking, that causes them to want to take a research year, because they don't have enough scholarly projects. And so you want to ensure before signing on that you're going to be productive in the experience.
I think being productive is a key, just like Monica just said. I did a 1 year in between ophthalmology residency and my ASOPers oculoplastics fellowship with Dan Albert. That's how I met Anne Tran when she was a medical student at UW-Madison. And that year with Dan Albert was so productive because it was studying pathology. And I think a lot of these good like fellowships or like year of research could be like a pathology year. I know at Bascom Palmer, they have a really good year for that. But that's the only thing I can add to what has already been said. That's really great.
Yes, lots of great information. Now we're going to turn to oculoplastics and ask questions that were submitted around that topic. Can each of you speak to the most interesting surgery that you have performed within the past 3 to 6 months, please?
I saw this question and I really liked it. But there are two that were really interesting. One was I had a patient who unfortunately was shot and the bullet was behind the eyeball, and I had to extract the bullet from behind the eyeball, which was a crazy surgery to do. And fortunately, I just saw this patient at his 6-week post-op. He was with the retina surgeon next door at Cook County, like in the other room. And his vision was 20/25. And literally the bullet was behind the eyeball, so that was amazing. The other one was I did a corneal neurotization surgery that we planned and successfully like helped this patient. And this is kind of a new technique in oculoplastics. I'm not sure when I'm going to do another one, but it was a complicated surgery and went well.
I guess I have a similar surgery with I think a corneal neurotization surgery that I did with the fellows, which at Bellevue, where Dr. Tran trained. But I don't think it was. Must have been after. Was it after your time, Anne? Yeah.
Yeah, just by a couple months, unfortunately.
Yeah. Oh, there was maybe it wasn't 6 months ago, but that was the first one I did of those, and I think that's one of the nice things about our field and ophthalmology in general is that you're always learning, and there's always new things to kind of new skills and new concepts to kind of learn as you get further on in your career. And I guess you could say that for a lot of medicine, but I think it's nice because you really have to go through all the steps of kind of learning how to do it and doing your due diligence and just trying it and having all those jitters and stuff. So it's a really exciting thing to try new things, I think.
Go on.
Oh, so I feel like my favorite cases are always the ones that end up being like joint specialty cases. So whether I'm working with like ENT for like certain decompressions, or maybe our skull-based team for like large skull, like sinonasal skull-based tumors, or my plastic surgery colleagues, I feel like those are the cases which are already so challenging. So they always challenge me as a surgeon, but then I'm fortunate enough where I get to learn from like other subspecialties. And so even though they may be long, like these are the only times I do like maybe like 6 to 8 hour cases, I always feel like I learned so much after leaving the case.
So it's good I'm going last on this question, because for the last 3 years, I had been appointed to be the Director of Career Planning Services at Mount Sinai Medical School. So I have actually given up my major cases for that period of time. But I've had a long career, over 30 years, and many, many, many interesting cases. As Dr. Tran just mentioned, the combined cases are some of the most interesting, particularly the ones with neurosurgery. I would do a transcranial superior orbitotomy. So they would do a craniotomy and move the frontal lobe aside and do their part. And then I would use their big CUSA, which is a cavitron unit, to basically eat away at the sphenoid wing tumor that was in the orbit. And so we had to remove the orbital roof, and it was just an amazing case. So that kind of thing is very interesting. When I was operating full time, the majority of my cases were trauma cases and a lot of functional cases for droopy eyelids and the like. But, gunshot wounds, knife injuries, assaults, car accidents, ton of sports injuries, orbital fractures, enucleations, mostly trauma. And then, your usual blocked tear ducts and your droopy eyelids and the like.
Thank you all for sharing. We could definitely sense the joy as you guys were speaking. The next question is, what conditions or reasons make up the bulk of your patient population? What misconceptions do you think people have about oculoplastics? What limitations, if any, have you faced in your practice? And examples are such as treatment options, patient understanding, referrals.
So as a continuation of what I just said, basically, when people ask me, what is it I do? I say, I fix this part of the face, which covers a lot. And I don't do much inside the eyeball itself, but everything around and behind it. Okay. And so that usually gives people a good idea of what we do. And earlier in this session, I mentioned how we can take tissue from all over the body to do our reconstructive work. And that's also very, very exciting. And that's one of the reasons that I chose oculoplastics as a subspecialty. I loved doing cataracts. I loved doing vitrectomies and retina work. I loved all the other ophthalmic surgeries. But personally, I felt I would get a little bored by doing a few procedures over and over again. where there are so many different procedures that we can do in oculoplastic surgery. I mean, I love everything else, but this is what fulfilled me. This is what fed my soul, so to speak. Okay.
I'd say the thing that makes up the bulk of my practice is eyelid surgery. So the most common things like upper eyelid surgery, blepharoplasty, ptosis, lower eyelid bag surgery, and then, brow surgery, cheek surgery. I mean, this is, almost everything. I also do obviously orbital cases and DCRs, but the most common is eyelid surgery. Let me see, this is a long question, so I'm going to read it again. What misconceptions do people have about oculoplastics? I think it's less misconceptions and more unawareness of oculoplastics. I think a lot of people just don't know oculoplastics exists. So I don't think there's a lot of misconceptions. There's just more of a, wow, that exists. I didn't realize there was such a thing, at least from where I'm sitting. What limitations have I faced in practice? Well, there are a lot of limitations at a place like Cook County where, there can be transportation issues, there can be all kinds of economic issues, compliance issues, so many challenges. But fortunately in oculoplastics, usually all we need is OR time to fix a problem, and so that's usually a problem that can be fixed. We just find the time, we do it when we can. And for the patients that show up at a place like Cook County, that's not too much of a problem. And then treatment options, patient understanding, and referrals. Yeah, I mean, I feel like in this day and age where I practice, I feel like there's almost like too much awareness. Like people a lot of times do so much research, they have ideas in their head of like what they want, or focus on the minutia and intellectualize things that can make it complicated to treat people sometimes. That's why it's such a relief to go to a place like Cook County and the patient will say like, what do I need, doc? And you just tell them and then you go do it and they're happy. And that's pretty much it. So it's kind of nice to have that balance.
Yeah, as Paul was saying, it's pretty small field. And so in terms of referrals and stuff, a lot of your referrals come from other ophthalmologists or optometrists. So you kind of have to be in a situation where you have a bunch of people that whether it's an academic or private practice situation, that are referring you things specifically for oculoplastics. So creating that network or being in a situation where that's possible is important. And you're not, every person that walks in your office is not always like a surgical patient. So you have to see a certain number of patients to do a certain number of surgery. And so it's kind of like creating that practice and business for yourself.
And I think I'll just address one of the later half questions, I think, like barriers. So oculoplastics is one where, there's a component that's both like functional versus like cosmetic. And so there's like specific criteria that the patients have to meet in terms of having functional like upper eyelid ptosis surgery or blepharoplasties. And even though like we may say that it looks clinically and visually significant, at the end, we're like kind of at the mercy of the insurance companies, whether or not they're going to authorize it. And the process sometimes becomes like very cumbersome. And I think that can be very just like annoying, but also challenging for the patients to like grasp sometimes.
Next question. Can you speak to the scope of oculoplastics compared to ENT, facial plastic surgery, and general plastic surgery?
I liked this question. I think it is a complicated thing to really understand. But from my point of view, oculoplastics is kind of like neck up, focused mostly on the eyelids. So we'd work on other parts of the body to take tissues, for example, to do a graft or something. But comparatively, I'd say ENT facial plastic and the things that we'll do that ENT won't do, for example, is usually like an enucleation, or orbital surgery, but some the surgeons will do like maxillectomy and exoneration. So some ENT like head and neck surgeons will do those kinds of surgeries in this area anyway. Plastic surgeons do surgery, head to toe, and they'll usually send patients to us, typically if they need, complicated like ptosis surgery or an entropion or ectropion surgery. And a lot of times plastic surgeons also send the complications to us from, blepharoplasties, for example, that didn't go how they wanted it to. So we end up kind of being the end of the line for eyelid malpositions, even if they're a complication from a cosmetic surgery done by other specialists. So that's where I see that we fit in. Some oculoplastic specialists in certain parts of the country will do rhinoplasties, some will do, full body plastic surgery. But from my point of view, oculoplastics is kind of neck up without doing many rhinoplasties, although some do.
And for me, I find that, kind of some of the stuff that Paul was talking about, like I like to keep my relationships with like my plastic surgeons and my ENT colleagues. So like personally, I don't do facelifts. Like I refer them out to my plastic surgeons, and in return, they kind of provide me ptosis. In terms of like the sinus surgery that I do, like I'll just do like endoscopic sinus surgery. But if someone needs like a septoplasty, or if someone it's like a complex revision, like decompression surgery, like I'll move my ENT colleagues in right away, because I feel like you'll gain a lot more by like not like stepping on like people's like turfs. And especially in a big city or an academic center, like there are already like certain like practice patterns there. And so sometimes it's better not to like rock the boat, especially early on in your career.
Yeah, that's important. And I feel like sometimes they really can be your best buddies, like the ENT and the facial plastics people. And it's important to have people that you can call and they can call you and you can operate together. It's really like a fruitful relationship.
One example of that collegiality is, excuse me, I have a bit of a cold. At my previous institution, it was sort of a turf battle in terms of who would do orbital fractures. So we had oculoplastics, we had ENT, we had general plastics, and we had oral maxillofacial surgery. Everyone wanted to do orbital floor fractures, okay? Just straight ahead, straightforward, without zygoma, without anything else. So what we did, we ended up working together by creating a call schedule. And for simple things for that night, whoever was on call, whatever service was on call, would get that case. And that way the residents got exposure. There was no bad blood between the different specialties, and there was more than enough to go around, because one of our hospitals was Kings County Hospital, one of the largest municipal hospitals in the country.
Yeah, I think working together is so great. With ENT, I did a orbitotomy. That was another interesting case from 2 weeks ago. A patient who like got pushed on the train track and had a orbital fracture of his lateral orbital rim, and an ENT surgeon and I together like repaired his orbital rim, and it was great for the patient. He, ended up doing really well with the surgery. And I think the combination of the two services working together on that case really gave that patient a better outcome. So it is great to work with the other services.
Next question, what can residents do to be competitive for an oculoplastic fellowship?
Okay, so I ran a fellowship in oculoplastics again at my previous institution. But that was also a while ago. Things are a little bit different now. Get exposure as early as possible, because there aren't a lot of spots available. And for ASOPers positions, they alternate the years for the 2-year experience. Get exposure as early as you can, form those relationships within your institution or elsewhere as early as you can, and try to get published if you can, even if it's case studies that you start with, case reports. Just get something, get the exposure, get the experience, and create those relationships. Ideally, getting a mentor. Unfortunately, I'm mentoring quite a few students and residents and college students at this point, so I really can't take on anymore, and a few of them are here. But that would be my advice at this point.
If you're thinking about matching into like oculoplastics and like an ASAPers program in particular, kind of when you're going through the residency process, a lot of times applicants have a lot better success if there is an ASAPers fellowship at that institution. And so for me, when I was like going through like the places of where I, wanted to do residency, I kind of looked at that as like, as a big criteria for me, just because it is a little bit harder. It's not impossible. It's just a little bit harder when there's not a fellowship already there.
I agree 100% with what Anne and Monica said. I don't think I have anything to add.
Next question. What emerging technologies are you most excited to see further developed in the next 10 to 15 years?
That's a good question. Yeah, go ahead. I was just going to say there was a recent article in iNet I think this past month about innovation, and Jeremiah Tao wrote something about oculoplastics because kind of like it's kind of notorious for not really changing a lot over the years, because a lot of it's surgical, and a scalpel is a scalpel, a suture is a suture. But a couple of things she was talking about was like the biologics. So there are new treatments for thyroid eye disease that have been game changing in terms of decision making with thyroid eye disease patients. So one of them is called teprotumumab, and there are new treatments for cancers that we deal with, like squamous cell cancers, types of immunologic treatments for melanoma. And so there's a lot of exciting new things that can be, in terms of those cancers, prevent the morbidity of a lot of the surgeries that may be needed, like removing eyes or things like that. So it's those things have been very helpful. And I think that's a very exciting new pathway within oculoplastics.
I was going to mention the thyroid eye disease treatment, which is very exciting and I think has revolutionized the treatment of thyroid eye disease, Graves' ophthalmopathy, and it really, really has made such a difference in many of my patients' life, eliminating the need for an orbital decompression. I'm a little less excited now than I used to be because of potential side effects that people are getting, but it's still quite a wonder drug, even at this point.
And then even in the like aesthetic portion of like oculoplastics, there's always, new neurotoxins coming on the market, which may last longer than your like 3 to 4 months is like your standard Botox. There's always new like soft tissue, like facial fillers with like interesting properties to kind of deal with like the more dynamic areas of the faces or deeper area of the faces, or that may last a little bit longer. And so that's a part I think that we sometimes like forget about, but the aesthetic portion is always evolving.
I like in oculoplastics the various instruments. For most part, it's pretty simple, but we do some surgeries with lasers. We do orbitotomies. Dr. Dweck was mentioning the CUSA. I like to do my DCRs with Sonopet, which is really cool tool to use. And I think within the surgical part, probably not a lot's going to change. The main changers are going to be the medicines for like thyroid eye disease. I'm a speaker for Horizon, and the medicine does help a lot. And there's going to be even more in the future. So the infusions for thyroid eye disease, those are great. Maybe there'll be an oral pill in the future, but that has made it more fun being an oculoplastic surgeon, because it used to be harder for those patients because there really weren't good treatments. Steroids didn't do anything, and decompression is a big surgery. I just wish someone would make a drug that got rid of chalasia. Like if there was a way to get rid of styes with just like one drop or something, that would be amazing. I mean, obviously not as serious as the cancer and chemos, and those are really helpful and great. But what bugs me is all the patients with styes.
Now I would like to open the floor to all attendees to ask questions. You can either unmute to ask a question or enter your question in the chat box, and Allison is going to monitor the chat box for us and read the questions aloud. Lily,
Well, perhaps we can ask a question. Okay. What is the representation here? How many are residents? How many are medical students? What years in medical school and residency? Do we have a sense of that?
We had pre-med students. I don't know, I think 4 pre-med students signed up, and then we had all class years, M1, M2, M3, M4. I think 2 residents registered. And then we had representation from all geographic locations in terms of California, Southern medical students, the East Coast, Midwest. I think Lily, you had your hand up.
Yeah, if that's okay. Hi, everyone. My name is Lily G. I am an N1 right now at NYU Grossman. Hi, Dr. Kim. And my first question is about what you find most rewarding as part of your day-to-day, and then also what, on the flip side, you find the most frustrating.
I can answer this. Right now, my favorite, most rewarding part is like seeing post-op week 1 patients who are extraordinarily happy and grateful, and they're like, wow, this changed my life. The most frustrating part is actually like telling people that they shouldn't have surgery, because there are some people out there that just no matter what want surgery, and you're like, I don't think surgery is right for you, and they just don't want to take no for an answer. So that's probably the hardest, most frustrating. And some of them have body dysmorphic disorder or other issues, and there's psychology goes into it a lot, but that's probably the most challenging thing.
One of the most rewarding things for me, I've changed cities, I've changed hospital systems, I've changed medical schools in terms of my career. I've been in private practice, I've been in part-time academia and full-time academia, which has been the largest part of my career. But throughout that time, patients have been able to track me down from city to city, from state to state. And some who I haven't seen, since I operated on them as children for 15, 20 years, they find me. And it's so incredibly gratifying to me. It's really a wonderful feeling.
I have to agree that with Paul, I thought that was really interesting, the frustrating part about, patients who, maybe you don't connect with, or they have different expectations regarding their care or their surgery. I think that can definitely take a lot of chair time and sometimes be very frustrating. I guess it is, I guess, a part of a lot of physicians' daily lives. Something that you get used to, especially as the more years you practice. Like patient selection for surgery is such a key important thing, and having those expectations and sort of the plan for care aligned with your patient is so important. So when that happens, that can be very rewarding on the flip side.
I see a question about step 1 and step 2. So since step 1 is now pass fail, step 2 has taken on even more importance. And so in most cases, taking step 2 and trying to really crush it can make a difference, because it is a standardized metric that people will look at, and that can make the difference in offering an interview or not. So ideally, it's best if you take step 2 in the early part of the application process. And remember, it's an early match. So you really have to think about the timing of step 2.
Yeah, it's interesting how step 1, like the pass fail of step 1, has sort of shifted some of the pressure to step 2. I think in this last application cycle, which was like the first one for us with pass fail step 1, it seemed that most people had taken step 2, but there were applicants, I think, that didn't have step 2 scores. And so I think there probably will be statistics on how many applicants did take step 2 or not, and who matched and forthcoming. But I think that's an interesting, decision, and probably most people will lean towards taking step 2 before the application is submitted.
And I think along with along with the step scores, I think you have to really make sure you do well clinically on all your rotations. So especially at, I think, the UIC system, I think it's still like the honors, like high pass, like pass kind of system within the clinical years. Dr. Kim and we had done a research project where we looked at like the qualities of like an outstanding resident. And one of the things that we found is that like applicants that had like 4 or 6 honors tended to be a better resident kind of overall. And I think that really speaks to like more so like your ability to be a team player, kind of like take advantage of like every rotation, no matter if it's your favorite rotation or least favorite rotation. So like if I saw an application where they didn't have their step 1 just said pass, but then I see their clinical grades is like through the roof, I'm like, okay, this is clearly like a good medical student, because so many physicians have graded this person and, have found them to be outstanding in all categories.
Part of the issue is also pretty much everyone who's applying for ophthalmology is going to have mostly honors. And so you absolutely want to try for that if you can, but you have to find a way to create your own personal narrative. What makes you unique? What is going to make you stand out and catch their attention? Okay. One can be a great step 2 score. Okay. And that's because it's a standard metric that, again, helps quite a bit. But is there something in your activities, your background, your motivation? And you probably are aware of how the application has changed. It's no longer just a personal statement. It's a bio sketch. And then you answer, I think it's 2 out of 5 questions. And that is where you can really demonstrate who you are, what you're about, what is your motivation, and basically what can you contribute to the world, to humanity, to the field of ophthalmology. So think about those things, and those are the types of things that can also inform your extracurricular activities. Find ways to be involved in leadership roles within your institution early on. Usually within the first and second year, you do that before you start your dedicated step studying for step 1. So if you can demonstrate that you've created something or been a leader in a group, those are all things that program directors look for. Okay, so step 1 is important, research is important, extracurricular activities are important, leadership roles are important, clerkship grades are important, letters of recommendation. You want to think very carefully about who you get your letters of recommendation from, okay? A generic letter from a named person is not going to do much for you. It'll do something because it is a name, but ideally, you want someone who can genuinely and authentically speak to who you are as a person. They know your work ethic. They know how well you work within a team, your communication with patients, all of these things. If they can give personal examples of how well you performed on their service, all of those things mean even more in a letter of recommendation.
Thank you for sharing. I think that was very helpful advice that everyone can take something from with that. And I want to be respectful of your time as it is 7 o'clock. We had a few more questions in the chat if you are able to stick around. Otherwise, I do want to take the time now to thank our panelists for joining us this evening. One of the other questions in the chat was, how often do you work with other subspecialties within ophthalmology?
I don't work with them very much. I mean, I see them in the clinic and I send notes back and forth, but in the operating room, not a lot.
I would say for me, maybe like once a quarter, there'll be like a combo case between me and another person between the ophthalmology, but then usually within like another subspecialty, like ENT, plastics, neurosurgery, that's at least once a month.
When I was operating a lot more, I worked fairly often. I would do combined cases with general plastic surgery, with OMFS, with a lot with ENT and some with the neurosurgeons. So yeah, fairly frequently.
There was a question about geriatrics. I'll just quickly address that, but I think geriatrics and ophthalmology go very well together. So if anyone's interested in those two things, you'll be satisfied. There's a lot of elderly patient population ophthalmology, whether you're doing cataracts or, we address a lot of age-related oculoplastics issues as well. So you definitely can spend a lot of time with a geriatric population ophthalmology.
So there is a question about working with subspecialties within ophthalmology. Again, somewhat often, for example, if someone has absolute glaucoma, and they're in severe pain and an NLPI, they will refer them to me. But in terms of actually being in the OR with them, not much.
If there aren't any more questions, I'd like to take this time to thank Dr. Dweck, Dr. Phelps, Dr. Kim, and Dr. Tran for your time, your enthusiasm, and your commitment to the next generation of ophthalmologists. Our next event will be in January, and when we have a date and time, we will send that information out. Thank you to all of our attendees for your participation. I hope everyone has an awesome winter break and a happy new year. Thank you.
Thanks for organizing this.
Thank you
Thanks
guys.
for organizing. Good night.
Good night, everybody.